Hello, hi viewers, good evening. I welcome you all on the behalf of Indian Medical College to this online class. Dear viewers, in today's session, we have a great energetic speaker, a beloved Dr. Sujoy Ray, who is an assistant professor from IQ Medical College, Durgapur, West Bengal with us. So he is having years of experience in his field and he's keenly interested topics on mood disorders, psychopharmacology, and schizophrenia. He is also has five publications in index journals, and today he'll be taking a class on the topic trauma-related disorders. Good evening, and I welcome you, sir. It's an immense pleasure to have you here with us.
Yeah, hi, good evening, everyone. So,
Okay.
I'm going to start off with this class today, which is on trauma related disorders. This actually, the thing with this group of trauma related disorders is that it is not, there are quite a number of disorders involved in this. And as you will see later, I have included some of them which which are very relevant, especially to today's world. And just to give you a brief overview, this is more of a class to give you an overview because every related disorder can be separately studied on its own as well. So to start off, let me just first come to this term trauma. So trauma has a very wide sort of meaning. Trauma actually means anything which is very threatening to a person. Like it could be whether it is threatening to your life, threatening to your identity, threatening to yourself. So it becomes a bit of a subjective term because some people may think of when they think of trauma, they may think of something like a catastrophe, natural catastrophe, like an earthquake or something like that. Or sometimes trauma can be something very individual, like you have sexual assault or rape, or it could be something like the loss of a relative, especially if it's a sudden loss when somebody loved one dies. So that way trauma is a very subjective term. It could have different kinds of different types. uh, the thing is that not all trauma, although when you say it like that, what I was just describing, it looks like it is sudden, and mostly trauma is like that, very sudden and something which happens unexpectedly, but it could be an ongoing trauma as well. Like, for example, you have something called as child sexual abuse. If a child is being abused by whether it's a relative, it's a friend or something, and nobody really comes to know about it, and that is happening over a period of time, so that is also trauma. It does not come suddenly. I mean, it may start suddenly, but it goes on for years together. It's not like your earthquake or sexual assault, which happens once and then you're at least it doesn't happen daily. But some kinds of trauma, like the ongoing child sexual abuse, can happen daily. I mean, can happen over a period of time. And the relevance of saying that this particular talking about this particular type of trauma is that it can get activated in the memory. Like if a person as a child was abused for a long time, later on the perpetrator of the abuse is not there anymore, but even in this adulthood, he if say he in his adulthood he meets that same perpetrator many years later, so the memory of that trauma gets activated. So what I'm saying is that we should not neglect ongoing trauma either. We should not only confine ourselves to sudden trauma when we are talking about trauma. See, the main factor in any trauma is a stressor. Now, whether it's a sudden stressor, whether it's an ongoing stressor, it does not matter. It can have a negative implication on anyone. Again, just to come back to what I said in the first time, the trauma is subjective, so different people may perceive it in a very different way. And this is important because later on, how they cope with the trauma is also, uh, related to that. Some people, it may not be a traumatic experience. Even an earthquake may not be a traumatic experience as they are hardened. Or for a soldier, it may not be a traumatic experience to have a bomb blast near him because he's used to it. But for a common man to have a bomb explosion near him is not something which he is used to. So again, as I said, trauma can be very subjective, and it should be always asked to the person that what is the significance of this trauma, or what is the significance of this event for him or her. So that is briefly what trauma is. I thought I'll start off with this disorder. This is something which is talked about a lot. This is called as PTSD, post-traumatic stress disorder, but sometimes it is used very loosely. People keep saying that I have PTSD after this, PTSD after that. Of course, some, I mean, you could have some particular features, but why, I mean, how do you exactly call it PTSD or post traumatic stress disorder? That is very important to know. So there are some very key features in PTSD. There is something called as hypervigilance. Now, as the name suggests, vigilant means the person is always alert on the move. Like normally a person will become alert or something when he needs to be alert. Suppose that he hears some sound in the night, or sometimes he needs to be alert when he's focusing on something like taking an exam. But a person who's had a trauma and he suffers from post traumatic stress disorder will always find it difficult to relax. He'll always be on the edge, on the go, sort of not able to loosen up. So that is called as hypervigilance. Um, that is one of the features. The other very characteristic feature is something called as avoidance. So anybody who's had a traumatic experience, like again, if we take the example of an earthquake, then that person will avoid anything related to that, anything which reminds him. So if it's an earthquake, he will avoid any news, or he will avoid hearing the word earthquake, even avoiding watching any show or anything on television which shows an earthquake. It may not be showing the same earthquake which he experienced earlier. And if it is a question of a bomb blast or something like that, the person will avoid that particular place, or the person will avoid that particular person with whom the trauma is related. So avoidance is a very characteristic feature. Then there is something called as numbing. Numbing means, as the name suggests, the person becomes numb, or sort of he does not have any sensations. Now, when I say sensations, I'm talking about emotional feelings, not not so much about physical sensations. So emotionally, the person cannot feel anything. He does not feel happy or even sad for that matter. The only thing is vigilance, always alert, always anxious, always worried that that particular traumatic source might attack him again. But otherwise, happiness or even sadness or other kinds of feelings which you have, or other kinds of emotions which you have, the person is not able to feel them. Then there is something called as flashback. So even though the person is not, I mean, he's avoiding the trauma, he's away from the stimulus, the person can have flashbacks. He could remember things. It could be the voice, it could be the images. This is not what we call as hallucinations, because the person will realize that this is not real. So this is not hallucination like you have in schizophrenia or in some other disorder, that you see something or hear something which is not there. So that's not the case. It's always the person knows this is false, but the person always has these kinds of flashbacks, particularly related only to the trauma. So we may see the face of his perpetrator if it's an abuse. He may see the bodies he saw at the site of a bomb blast, or may hear the sound of the bomb. And any small sound, I mean, just connecting to this and hypervigilance, any kind of small sound can trigger it off. Any small sound gets very highly amplified, and the person feels as if I am hearing this, as if it is the bomb blast, or as it is the traumatic event which he is hearing. So these are some of the core features of post-traumatic stress disorder. And how does it? Why does it happen? So they now, if you know that there are these two important organs in the human brain, hippocampus and amygdala. What basically happens is, hippocampus is the storehouse of memory. I mean, hippocampus is basically where the short-term memory is converted to long-term memory, and amygdala, just to say roughly, it is related with the emotions of fear and anger. Although hippocampus also has some role in anger, but usually amygdala is the one which is more sort of connected to fear, emotions of fear. So basically, if there is a mismatch between the two activations of these activation of these two organs, so hippocampus may help you in remembering certain details about, say, if there is a traumatic event and you remember those details, where it happened, what happened, who was present, and that is fine. There is nothing wrong in remembering that, because that is fine. That is a part of memory. And amygdala is the place where the emotion related to that will be stored. The fear related to that, what fear you felt at that point, what emotional disturbance you felt, what kind of emotions you had that point, that will be stored. Now, if there is a mismatch between these two, that the emotional part becomes so overwhelming that you don't have any clear memory of the incident as such, but you are always having the fear and you're having those flashbacks. So when there is an imbalance between this hippocampus and amygdala, if amygdala works too much, and that happens, I mean, that depends on the individual's sort of constitution of how the individual is. And if that happens, it is then that the fear component increases, and the memory component decreases. Even PTSD victims will have difficulty in recounting the exact details of the incident, but they'll remember the fear part of it, and they actually, as I said, they will avoid it. So then that brings us to the next point of vulnerability. So people, different kind of people are vulnerable to PTSD. So people who've been frequently exposed to trauma are more vulnerable. Then children are sort of more vulnerable because their coping skills or their mentality or their psychological power has not completely developed. Then people who already are suffering from some mental health disorder, whether it is depression, whether it is schizophrenia, whatever it is, or things like alcohol abuse, they become more vulnerable. People who have a family history of mental disorder become more vulnerable. People, like what I was saying, people who have faced chronic abuse or chronic trauma in their childhood are more vulnerable to get PTSD when they are exposed to a sudden trauma again. What I was talking about, the reactivation of the memories. So these are some of the factors which can govern whether the person will develop PTSD in the future or not. Another aspect is guilt. Many times, whether it is, like if it is a bomb blast and somebody, although he escapes from it, he feels, he loses a loved one or loses a friend or somebody dies, or even in case of sexual assault and rape, there is sometimes a feeling of guilt that maybe why did I survive, or maybe I brought it on myself. So this feeling of guilt can also contribute to the formation of PTSD. It could be a guilt of anything. It could be guilt of survival, that I'm alive and he is not alive, and it could be a guilt that I brought it onto myself. So that could be another factor. And what I was saying is faulty memory or recall is the same thing what I was talking earlier. So if you cannot recall the exact incidents, the exact factual parts, it is the emotional recall which sort of overtakes the factual recall. So these are some of the factors. It's very difficult to say if you look at why people develop PTSD, but these are some of the risk factors or the etiology which is involved in it. Coming to treatment, again, so any disorder, we know that it has, in psychiatry, we have a pharmacological treatment and we have a psychological treatment. So medications, pharmacological treatment, what is most recommended is selective serotonin reuptake inhibitors. In that also sertraline seems to be a little better, but there are different studies, so they say different things. Things like benzodiazepines, which we give for sleep and anxiety, they are not very helpful, because the whole point here is to not to, the person is already numb, the person is already not able to recall or remember things. And if you give medicines like benzodiazepines, which include induce sleep and all, that is very, it suppresses the memories even further. So our job is not to suppress the memory, it is to reduce the anxiety and the fear associated with the memory, and keep the help the person come in terms with whatever has happened. So it is not very helpful to use things like, it is not advised to use things like benzodiazepine. However, the main treatment is psychological. So you have something called as trauma focused CBT or cognitive behavior therapy. Now this is a very intense, and it's a very detailed, about 10 11 steps are there. But just to make it very simple, cognitive means thoughts, what I was telling earlier, thoughts of guilt, thoughts that why did I survive, I did something wrong, and those kinds of thoughts. And behavior means what the behavior the person is doing. He's avoiding those things, he's always on the move, always vigilant, always anxious. So basically we are addressing, in this kind of therapy, we are addressing those thoughts, we are rectifying those thoughts to help the person remove the guilt and so on. And we are also improving the behavior of the person so that he does not avoid, he comes to terms that whatever has happened. And say if an earthquake has, he's suffered an earthquake, then he should not continuously keep on avoiding news about earthquake or avoiding newspapers, just that because he's afraid he'll say something about an earthquake again. So that kind of behavior is not appropriate. He can't keep on doing that all his life. So we improve the thoughts of the person also, and we improve his behavior also. So that is very roughly talking about what CBT is. So that involves a lot of steps. Thought, how do you improve thought, is by talking to the person, helping him to understand that why what this happened is not his fault, and helping him to challenge those faulty memories, what I was saying earlier. The faulty memories or the faulty recall are challenged through therapy. And behavior therapy includes things like relaxation, so teaching him relaxation exercises. As I was saying, the person is always on the move, always very anxious. So how to relax, whether it could be breathing exercises, It could be some muscular relaxation exercises. We could discuss that in more details in the later classes or other places. But those certain exercises can be taught to a person, and that would help them relax. So usually we have a treatment which is combining both the modalities. We do not exclusively use only one modality, but it depends on the condition of the patient. And it's very difficult to say how long the treatment should go on, maybe for a few months. It all depends on how the person improves and what his previous functioning was before the disorder started. So this is a new sort of a novel treatment which has come up for PTSD. This is called as eye movement desensitization and reprocessing. Basically, what it means is that when a person moves his eyeballs, like using his extraocular muscles, looking from one end to other, it is believed that the movement of this eyeballs, the movement of eyes is connected somehow to the memories. So if it could be a guided movement, like for example, if it's something very simple, like a therapist is moving his finger and the person follows the finger, or now more developed things like computers and all have come, so a dot is excuse me, dot is moving across the screen and the person follows the dot. So those kinds of movements of eyes, it is not exactly clear how they do it, but they help in reorganizing the memory, removing the guilt, and basically it helps in coming to terms with the trauma. There are only very few centers which offer these kinds of treatment, but this is a new novel technique that people could read up, and this uh, does not have any side effects or anything like that. The only thing is that it would take a lot of time for the reorganization of the memories. So this is about post-traumatic stress disorder very briefly. Now, two disorders which are very similar, but they are not exactly the same things, is something called as acute stress reaction. So acute stress reaction means that it will start in a few hours. I mean, if the person has been exposed to a trauma or a stress or anything like that, uh, but it will be there for a few hours. The person will again have similar features, very anxious, maybe there's a lot of emotional turmoil, the person is not able to relax and those kinds of things. But usually things like flashbacks and emotional numbing is not present, and it would go away in a few hours, or it would go away immediately after the stressor. If the stressor itself goes away, the feelings will also go away. It will not persist like PTSD persists. Similarly, you have something called as adjustment disorder. So adjustment disorder, what happens is, again, it is following a stressor, but this is something completely, comparatively mild. It does not have numbing or extreme emotional hypervigilance or things like that. There is some disturbance in emotion and behavior both, just like PTSD, but again, it is not very intense. It is not, there are no characteristic features like PTSD, like the person will not actually actively avoid things. They will not experience flashbacks. They will not experience numbness. They might express some features of sadness. They might express some features of anxiety, maybe both, some amount of disturbance in their behavior, sometimes getting irritable and all that. But that is actually much milder than what happens in PTSD and does not have the same features. But these two disorders are also related to stressors. And again, they both have similar psychological interventions, although it is not exactly like what we were discussing in PTSD. But again, psychological interventions to help them to come to terms with the stressor, come to terms with the problem, and some amount of pharmacological treatment from things like SSRIs can also be given. Now, coming to something called as dissociative disorder, dissociative disorders are also linked to trauma. It is not exactly the same as PTSD or the adjustment disorders and what we were discussing, because they may actually not, they don't actually come right after the trauma. I mean, like in PTSD, you have a trauma and then you have some of these disturbing features which start off. But dissociative disorders, they may not necessarily come right after the trauma, but the origin of these disorders are in trauma. I mean, the reason for these disorders are related to some kind of trauma which people have experienced earlier. So I'll just make it a little more clear as we go through. First, let us understand what is the meaning of dissociation. Now, every individual has certain aspects. I mean, like if you see things like he has some sensory aspects. I mean, we are aware of the world around us, isn't it? We can sense certain things. We can sense. I mean, we can see certain things, hear things. So those are the sensory components. We have cognitive component. Basically means thoughts. We are having some thoughts about what we are going to do today and how things are and so on. And there's a motor component. So we are in control of our body. And there is also an identity. We have a memory that we know who we are, where we are, what is my name, and so on, those things. In dissociation, these things get disturbed. They actually get, so dissociate means to separate. And these things get separated or they get disturbed in the phenomena of dissociation. I'll just explain how it happens by some example. So basically, dissociation is a sort of a defense mechanism. So if we have an anxiety, if we have an anxiety which is there, like again, I'll go back to the example of child sexual abuse. Somebody has had a child sexual abuse. Now the perpetrator is not there, but the memory is still there. The anxiety, the some guilt, all these things are there. And when suddenly, out of the blue, suddenly that emotion becomes too much, the person starts to remember. Maybe he sees the perpetrator somewhere, receives a phone call from the perpetrator, and suddenly that anxiety increases. So to relieve that kind of anxiety, because it's an uncomfortable feeling, it's an uncomfortable aspect, the phenomena of dissociation starts to work, and the person is not consciously doing it. This is something which happens on its own. The person is extremely anxious, and then suddenly he will start to dissociate. So that is it, he's not actually aware of this phenomena. Now when I say the person starts to dissociate, why does it happen? Why would a person have difficulty in his motor functions, in his sensory functions? There is something called as a gain. So gain means that if the person shows that dissociative phenomena, if there is a disturbance in the person's identity or his motor aspects or his sensory aspects, like for example, somebody may suddenly say that my hand has become paralyzed. When a person has this memory, has this anxiety related to the some trauma he experienced in childhood, and the anxiety increases, suddenly his hand becomes paralyzed for no known organic reason. So what happens? Why does this? Does that happen? Why does the person's hand become paralyzed? Because his anxiety was suddenly through the roof, and once the hand became paralyzed, the psychological anxiety went down. The feeling of anxiety went down. So that is called as primary gain. Secondary gain means that if the person's hand is paralyzed, they will get some attention from the surroundings. People will be asking him, "What happened to you suddenly?" and so on, so forth, and that will further reinforce the belief of the person that if people are around him, it will give him a sense of security that will further relieve the anxiety. The person will get reassured that that perpetrator or whoever did this to me cannot come to me, because now all these people are with me. Then there is something called as a tertiary gain. So he will not have to go to work. I mean, people will obviously advise him that you're having this problem, don't go to work, don't go to school. So what will happen is that he doesn't have to. Now his anxiety has come down. He has got some attention from people who are surrounding him, and he does not have to go to school, go to work. So this is a sort of a safety he has gained. Now he's saying, now he feels that I am safe. Now I people are around me, I don't have to go out. There is no chance that perpetrator or that traumatic source will again come in contact with me. So this is just like he's building up a safe environment around him. So that is the concept of dissociation. Just to review, basically, if you have a particular kind of stressor, and when you have the stressor and the psychological trauma becomes too much, when you start remembering the stressor, you develop some physical symptoms, and as a result of physical symptoms, you develop some attention from people who are surrounding you. You don't have to go out or anything like that, and you feel a sense of safety. So that is what the phenomena of dissociation is. Now it can be of different type. For example, dissociative amnesia. Again, so if the person has had a traumatic experience like a sexual assault, he or she will forget that particular time. Supposing the assault occurred from 4 p.m. to 5 p.m. on a particular day, so the person doesn't remember anything. Now, you have got certain other memory loss problems like dementia or organic symptoms where you got head trauma or alcohol, but there you will not. There the situation is that you don't forget memory in bits and pieces or circumscribed memory like this. Dissociative amnesia, you only forget, the person forgets that particular traumatic period of 1 hour, 2 hours, days, whatever it is that happened for him, and that becomes like a gap in his memory. He does not remember that particular time, but he remembers everything else that happened around it. So that is called as a dissociative amnesia. Dissociative fugue, what happens is, this is another different way of coping with stress. The person will suddenly just simply wander away from that place. So if there is a problem in the family, if there is some kind of perpetrator of abuse in the family, the person would just leave the place, go to some other place, and the person actually takes up another identity and begins a new life and stays there and does not come back. So this is a way of escaping a traumatic situation, and this is called as dissociative fugue. Coming to dissociative identity disorder, now this is some maybe a bit easy to understand. What we call a split personality in normal in a normal language sometimes. Like if the person is very sort of shy, meek in real nature, and that particular person has suffered a stressor, that particular person has suffered an abuse, suffered a trauma, then he will take up a different identity. What happens is that suddenly, like what I was saying in case of dissociative amnesia, they forget what they are. They forget a particular part of their time, but here they'll take up a new identity. So the person will suddenly start speaking in a different voice, behaving like a different person, say for an hour or a couple of hours, and he will be very opposite to what he is. If he's a shy person, in reality he will talk like a very angry person or a very authoritative person. And after the person goes through this, he speaks in a different voice, he behaves like a different person. After some time, he starts speaking in his normal voice and comes back to his normal self, but does not have any memory that he was behaving like a different person. Once the person comes back to his original self, he does not remember what he was doing when he was behaving like that different person. So this taking up of an alternative personality is a sort of a way to compensate. Like if the person feels that I was shy, I was meek, I was very withdrawn, and that is why I became an easy target for a stressor, I became an easy target for a trauma, that is why, to compensate for that, he takes up this identity. But since this is happening at an unconscious level, the person does not even realize that he has been doing this. So this is what we call as a dissociative identity disorder. What I was talking in the first time, dissociative motor or sensory loss. So a person, if suddenly there is an increase in the person's tension, in the person's anxiety, there is some kind of difficulty, the person will start developing physical symptoms, tingling, numbness, paralysis. But the thing is that this tingling or numbness or this paralysis is not neurologically explained. It does not conform to a dermatome. It does not conform to any tract or anything like that. And the difference between neurological paralysis and this is that if you do any kinds of test on the person, reflexes will be normal. And again, so some simple ways are there. Like for example, if a person says that I'm feeling paralyzed and he's lying on the bed, so to test whether that paralysis is dissociative in nature or whether the paralysis is organic in nature, if you raise the person's hand and let it drop on the person's face, in case of a neurological disorder, it will just drop on the face. But in the dissociative disorder, you raise the arm, you let it drop, the person will consciously avoid his face and make it hit some other part of the body, because the person retains that much of consciousness so as not to hurt himself. So this is what is dissociative motor loss or motor or sensory loss. So this is one way of dissociation. The other way is dissociative seizures. This is also a motor phenomena. So what happens is that the person suddenly throws what looks like a seizure, but this is non-epileptic in nature. It is not your tonic-clonic movement. There is no aura. There is no tongue bite, incontinence, no eye uprolling. If that time any EEG is done, you will not find any abnormalities. You will not find any post-ictal confusion, post-ictal headache. And again, this is triggered off by a stressful situation. If the person encounters stress, if the person has a rise in his anxiety, if a person has a rise in his, if basically he remembers a trauma or anything like that, he will have these kinds of seizures, which are not actually epileptic seizures. There will be some abnormal movements, some movement of hands, some movements of heads, something like that will be there. And again, these types of seizures will last for abnormal periods of time. They will not be very short. They could be very short, they could be very long, they could last for hours together, which does not happen in normal which does not happen in organic seizures. And this will continue until the anxiety and the stress is relieved. And again, as I was saying earlier about gain, once the person is there is some secondary gain, people are helping him out, people are giving him attention and those kinds of things. That is what the seizure basically, that is what is the outcome of that is what is the intention, that is why this is happening. Once he gets that attention, once he gets that gain, the seizures will stop. So how to treat all these phenomena, with whether it is a dissociative amnesia, whether it is a dissociative seizure. So that has to be, I mean, the treatment for this is basically treatment of the stressor. There is no other way. I mean, if until you address why there is a stress, why is the person stressed? Is it a problem in the family? Is it a child abuse which happened earlier? Is it some other trauma which he has not come to terms with? So it is important to talk to the patient, talk to the family, and get proper history, and then after that try to understand that how, what was the chronology, is why did these dissociative symptoms start, why is the person since when is the person having this paralysis, since when has he been having these seizures, and since when has he been having these memory losses. And you will find that there was some kind of a stressor which was early, which is either new or something which has been reactivated, and then you'll understand that all these things happened after that. So that stressor should be addressed. If it is a conflict in the family, family therapy must be given. If there is a potential perpetrator of abuse which is still around him, that protection from that abuser should be given, or punishment to that abuser should be given. And the and if there is some other kind of trauma which the person has seen, and the trauma is still there, so the therapy should be given in such a way that the psychological aspect of the trauma comes out, the person talks about it freely, and once that happens, once the trauma is resolved on a psychological level, then the physical manifestation, whether it is motor, seizure, memory loss, that those things will automatically reduce. Now, supposing a person is having a dissociative episode, I'm not talking about the amnesia and the fugue and the identity, because it's very difficult to deal with them at that point of time. But if supposing the person is having the seizure, or the person is having the paralysis, what should you do at that point of time? As I said, that any excess attention given to him, like if you try to hold him, if you ask him what is going on, what are you doing, that will sort of perpetuate the phenomena. So actually what is the treatment is to ignore the phenomena. When I say ignore, it does not mean that you completely ignore the patient. You cautiously ignore him, you keep an eye open that he should not hurt himself or something like that, but make sure not to not to give him too much attention, not to hold his arm, not to ask again and again, what happened to you, are you okay, this and that. So that should not be done. Sometimes a strong stimuli can be given to the person, like for example a small, although this is very difficult to do, what we call as grounding. So they say that if you give a strong smell or some strong stimulus to the person, which a very pungent kind of smell, that will sort of activate the sensations in the person and help the dissociative phenomena to stop at that point of time. It can abate the seizure. And again, medications, again, it's not very I mean, it's not very useful to give, but at that point of time, if it becomes too much, then you can of course give some injections of sedatives like benzodiazepine and temporarily stop the phenomena. But as I said, medications and excessive attention given to the patient will actually only perpetuate the phenomena. So it's not really helpful in that point, really helpful in the long run. It may be helpful at that point of time. Now for fugue, amnesia, and identity, again, the main treatment is psychotherapy. But what you can do is you can ensure that if in a fugue the person has walked away, then it should be ensured that he's all right, he does not hurt himself, he does not go away and hurt himself. If the person is taking up a alternative identity and is behaving in an angry way, then injury should be prevented to himself and to others. So that is the only thing you can do for these particular disorders. Otherwise, in the long term, it is the therapy and the psychotherapy which is required. So just to summarize what I was talking about, we first talked about trauma, that it is subjective in nature and it depends on different types. It could be sudden, it could be ongoing, but it has to be something which is life-threatening, or at least something which is perceived to be life-threatening by an individual. Main disorders, what we talked about was PTSD and the factors of hypervigilance, avoidance, numbing, and having flashbacks, and some other disorders like adjustment and stress, which are not as intense as PTSD, but are stress set off by stressors. So we've talked about pharmacological treatment by SSRIs and psychological treatment by cognitive behavior therapy, and also the EMDR. And as far as dissociation is concerned, just to recap, that it is a separation of all aspects of cognitive perception, motor and sensory phenomena in a person. It could be a motor phenomena like a paralysis, it could be a seizure, it could be a difficult disturbance in the person's memory. It could be a different identity being taken up by a person. It could be a fugue. But all these things are basically happening so that the person's anxiety reduce and he gets relief from it. So that is why the main treatment here is psychotherapy, and to help him come in terms with the stresses. Although we can use, as I was saying, some medications and some other approaches during the phenomena itself. So yeah, that is it. And I'm happy to take any questions. And as I said, trauma is a very intense topic. There's a lot of things: PTSD, dissociation. They are all individual topics which can be discussed in great detail. But this is more to give you an overview of what trauma is and what kind of implications it can have on an individual.
Thank you so much, sir. It was a very detailed explanation of the trauma-related disorders. Dear viewers, I hope you have enjoyed sir's session. And sir, can you please stop sharing, sir? Okay. Thank you for a nice session, and I hope all the students and the viewers have enjoyed the session. And dear viewers, please share our YouTube channel, and these are the links, and share our Facebook page. You can also access the recorded videos, MCQs, and the announcement of all the sessions at our Facebook page. And this is the upcoming session for today, and which is on the topic molecular basis of cancer. And this is being splitted up into part 1, 2, and 3, which has been taken by Dr. Satyamurthy from Katuri Medical College, Guntur, at 6:30 to 7:30 session. This is the upcoming schedule for tomorrow. We have 2 sessions. One is on 5 to 6 p.m. by Dr. Swaminathan from Tirunelveli Medical College on the topic peripheral smear preparation and interpretation. And the second session is at 6:30 to 7:30 p.m. taken by Dr. Girija Sivakumar from Karpakavanayaga Medical College, Chengalpet, on the topic parotid and submandibular gland exam revision. So viewers, if you have any queries or any clarification taken on the session today, you can just type them in the comment section below and sir will answer them later. Thank you, sir, for the wonderful presentation. It was a very well explained and the detailed session. Thanks for the informative session, sir.
Thank you. Thank you.
Okay, thank you and see you all in the next session, viewers. Stay tuned.